All right.
If you want to hold it, the
Like,
closer you hold it, the better.
yeah. Right. Okay. Good day. I welcome everyone to our inaugural session where we discuss about mostly emergency-related topic when it comes to IMGs and coming and working in Australia. So I have the great honor of having Dr. Sav today, which is someone I recognize as who, at least in my part of my journey when I came in here, who did a great deal of work for me to feel welcome and make my transition easy coming from very different backgrounds. So welcome yourself today. so thank you so much for participating today and making your time and being a lecturer from the JC University for medical students and for working as a full-time consultant in the emergency department as well. I think thank you so much for making your time. How are you doing today?
Yeah, not too bad, Supun. Thank you for inviting us to have a little chat. We're here in the kind of the courtyard of
Yeah.
Townsville Emergency or Townsville Hospital. Um, but yeah, no, I'm doing really well. I'm excited to kind of answer some of the questions that you might have had and see if we can share stories about how to navigate that difficult journey of being an international medical graduate in an Australian health system.
Right. So introducing SAF, which is a question that I sort of struggled with over the last week, ever since you agreed to this. It's just, I think if I describe you the first time I met you, I think given our spectators, this is the first time they are meeting you as well. So it was during my first week when I started working here, and I was doing this orientation where I had to follow around a senior medical, like a senior RMO, and sort of learn on the job. And I was terrified. And I think you were supervising interns that day. I don't think you remember
Yeah,
that.
The
Molly,
Molly
yeah, Molly.
consultant, yes.
So I think you kind of noticed that I was terrified the way I was behaving. So you came in. I had no idea who you were, and you came in. You introduced yourself, and then you just asked me how you're doing. And at that time, I was just sort of you caught me off guard, and then I said, I'm supposed to do this by myself next week, and I'm terrified. And what you said, like you always expect someone to give like a very, like a garden variety answer when you give a sort of like that sort of a feedback. And what you said was like, look around you. You have so much people willing to help you out. Just not by yourself. You're gonna be fine, and before you know it, you're gonna start enjoying it as well. So that sort of actually quite relaxed me quite by a bit, seeing the support available. This stranger who I didn't knew came in, introduced yourself, and just sort of made my life easier. So to be honest, actually, the first 6 months I worked in the emergency department has been the most fulfilling and most satisfying 6 months ever in my career. Yeah, it's a yeah, because I came from like anesthesia, ICU, cardiology sort of a background. The work was not always as bad as some other EMGs would experience, but it's been quite fulfilling, and I felt like actually I belong to the department.
Good, good.
So yeah, so Saf, without further ado, just please tell us about yourself.
Yeah, so I'm an IMG as well, international medical graduate from New Zealand. I was born in New Zealand, but I actually grew up in Papua New Guinea, which is a country north of Australia, a developing country, and I did high school there till I was 18. But because I had a New Zealand passport, I was able to do medical school in New Zealand. So I finished my medical degree in New Zealand and then worked there as a junior doctor for about 6 years, and then came across to Australia in 2010. So that's about 15 years ago now, as a registrar. But yeah, so technically I am an IMG as well. But I think the relationship between New Zealand graduates and Australian graduates, it's a very close. They're like Australia and New Zealand are neighbours. They kind of got a sibling rivalry, and the training program is across Australia and New Zealand for emergency medicine, and that's my specialty, emergency medicine. But yeah, it is still a transition going from your home country of training, moving to another country, and trying to adjust to the different systems. So I certainly had a bit of an adjustment, just getting to understand, the different ways we prescribe, the electronic health record, which is in Australia. We have that in New Zealand as well, but it wasn't quite at the same, at many differences. But I think culturally, the adjustment to Australia was fairly easy. Um, Not really, some of the cultural challenges that I think you probably experienced coming from quite a different background. But yeah, ethnically, my mother is from Samoa, which is another little tropical island. Hopefully, people in the audience can visit there one day. Beautiful place. And then my name is Arabic, Zafar, because I was brought up as a Baha'i, a member of the Baha'i faith, and so my parents wanted an Arabic name to go with Smith, which is my surname, which is from my English side. But anyway, that's a little bit of background, but yeah.
So, emergency medicine. So that's where you ultimately ended up. I hope by choice. So, it's. I would say it's like I can't say not even close to being an expert on the subject, but as far as I understand, most people, like if I speak about our rotational RMOs, they would be like, "Oh, emergency! All right, can anyone swap, please?" So that's sort of like they do have that sort of. I think it depends on the person. So, what made you become an emergency physician?
That's a good question, and I think you're right. Often when people say emergency, they think of stress, night shifts, difficult trauma patients, and a lot of stressful times. So it's not kind of the first thing that you're excited about. For me, my journey, I never thought of emergency medicine. I didn't really know that was a thing. Actually, when I graduated, I'm 21 years since graduation now, but back when I first graduated, I thought I wanted to do 3 things. I wasn't sure which one it would be, but I thought psychiatry. I really enjoyed chatting to people and understanding how the mind works and how it can go wrong. I also was interested in pediatrics. I loved kind of engaging with kids and trying to understand how to make diagnoses with kids that can't always give you a good history. And then GP, general practice. So when I first graduated, I tried all of those 3. So I did 3 months in psychiatry, and I was like, oh my goodness, it was really challenging. People with psychosis and schizophrenia, you treat them, but then 3 months later, they've stopped taking their meds and they're back to their baseline. So I realized I didn't really want to do that. Then I did pediatrics. I did a diploma in pediatrics, but there was something about outpatients and clinics that I really didn't enjoy. That kind of long-term chronic management I didn't quite enjoy as much. So I kind of moved away from peds, and then I did GP. Again, that was only for 3 months. But I think just with I really liked high-paced, variety, and I found that the 3 months that I did of GP, I didn't quite enjoy as much. And then in my 4th year as a junior doctor, I was as a SHO, I did 3 months of emergency. And there was a lot of people with mental illness. There was a lot of kids, and there was a lot of GP presentations with, coughs and colds and sore fingers and minor infections. So I thought, oh wow, this has got everything that I liked, but it didn't have the outpatients, it didn't have ward rounds, things that I didn't really enjoy. So then, I didn't look back. So that was my emergency journey. It had pretty much all the things that I was interested in. The shift work is a big challenge, but when I was doing my training program, we homeschooled our kids. So my wife and 3 kids at the time, because I was doing shift work, it actually meant I was at home during the day and could spend more time with my kids and then come for like an afternoon shift. So the shift work actually worked really well for our family. But that's really a big barrier that a lot of people struggle with. And if you can work out how to manage the shift work, and if you can find a way that it outweighs the benefits, outweighs the sleeplessness, then usually, yeah, ED can be a very fulfilling career.
Yeah. All right. So times have changed a bit since like when you came from when you decided to become an emergency physician and from now. But for IMGs, it's just a bit of a question whether have they been improving or whether they've been the same. So what were the specific challenges that you felt when you started out as an IMG?
Mm. Challenges as an IMG. I think culturally there weren't that many challenges because coming from New Zealand to Australia, that wasn't so hard. But um, maybe I can share, talking to other IMGs and also as junior doctors,
Yeah.
some of the challenges working in the emergency. I suppose there's three things. One is the flat hierarchy. So in emergency, there's less of a difference between, I guess, the ED consultant and the juniors. You're talking one-on-one to an ED consultant. The ED consultant's coming and seeing your patients. In the ED, I think some IMGs have said, oh, you just call them by their nickname. Like, oh, Brownie, Strico, or, in Australia we shorten their last name and you make it a slang. So the more flattened hierarchy compared to like if you're on a surgical rotation, there's often a perceived bigger gap between, I guess, the surgeon and the RMO, so to speak. So I think in ED that can be a bit of a challenge or a cultural change. Oh, you can actually approach. I don't know. I like to think ED consultants may be a friendly, approachable, and generally engaged and want to show an interest in what you're doing. That's not to say other specialties aren't like that, but certainly in ED there's a more flattened hierarchy. I guess the second challenge that sometimes I've perceived or that other international medical graduates have also faced is nurses. So nurses are extremely knowledgeable, talented, have a lot of vision, a lot of experience, but it can be a challenge where nurses can, question what you say.
Exactly.
Dr. Supun, I don't think this is the right dose, and I don't think we should be giving adrenaline at 5 milligrams as an injection. But that can be sometimes challenging where nurses, particularly in Australian culture, they are very clear and they have very good insight a lot of the time to direct and question doctors' thoughts. Let me just check if it is. So I think just recognizing the role of nurses in Australian health system, is really important. Would you agree? Like that's sometimes in different cultures.
It's just from my experience, the nurses will do whatever you say, as you said. Like it's not like they don't know. It's just looking at like they have probably because of the workload as well. So they have there would be 3 nurses looking after 100 patients sometimes, certain nights. When I was an intern, that was most of the time that was the case. So they didn't have, they were a bit overworked. They haven't been for a break in a while, which is something quite serious in Australian setting, because I've seen nurses being forcefully sent on breaks, not against their will, but that's they're the team leader. She's very keen on getting everyone out, and if they're going to do something which is not that urgent, they would always mate, go for your break, come back. So which is not affordable where I come from. And it's a bit unfortunate situation because there's no proper triage system. You will get 100 patients in 50 beds, the other 50 would be in the floor, under the bed, God knows where they are sometimes, in the corridors. So so I have found myself they don't question you just because they believe that you're doing wrong.
Correct.
They question you, they want to know why. So I believe the very first instance when you just said that, it came into my mind. I had a girl, some 20 years old, came with diarrhea, and when I asked her past medical history, she was on lithium. So then I checked up like lithium toxicity, and the ECG was indicated. So I ordered for an ECG, and the nurses came and asked me, "Why are you doing an ECG on a gastroenteritis?" And I said, "No, she's on lithium." So I mean, I don't think she's actually
Yeah.
toxic, but I just want to see whether there's anything that I should be worried about. And then she said, "Okay, okay." That was it. End of discussion. And 5 minutes later, I see the ECG. Yeah.
Culturally, back in Sri Lanka, no questions.
No, how dare you? That would just, I mean, it's something that I truly appreciate, and the involvement from the nurses, as you said, is quite brilliant. You know, you learn a lot of things, and it is you're a team. You know, like it's not you're not trying to one up each other. You're a team, and you just sort of if you work together well, in the end, the patient will benefit, and you can hopefully discharge that patient sooner, and everybody will be happy. So
I'll just add on. So I think there was 3 challenges I was going to share. One is sometimes the flattened hierarchy that can be a bit of a cultural change. The second was the nurses and the important roles that they have. But the third is the patients.
Yeah.
So I think that's a huge cultural difference. Is patients in Australia will often can sometimes argue with you, or often disagree. I don't want to go home without antibiotics. I want antibiotics. That's why I'm here. Or so the expectations of patients in Australia might differ from other cultures, in that often they'll come in with a certain expectation, and if you don't meet that expectation, you can have complaints and arguments and things. Often this idea of drug seeking. So unfortunately in our society, addiction to addictive substances, methamphetamines, alcohol, cannabis, these are all addictions that exist. And so often patients can come in with, say, chronic pain and requesting opiate scripts. And so that can be, another challenging thing, where meeting patients' expectations and trying to navigate those difficult communication discussions. So, I think, would you say that is a challenge as well, the expectations of patients in Australia?
I mean, yeah, it's just, like in where I come from, there's a bit of a patriarchy, Doctor will say and the patient will do in 95% of the cases. Only thing that I would say it's different is the young patients, which would, like consult Dr. Google 30 minutes before they come in, and then they will have these questions like, like I felt my heart race. Am I having atrial fibrillation? Like stuff like that. So, but as I said, like I do experience this quite a lot when I work as a GP, because when I started out, GP is a whole different thing.
It's Sri Lanka.
No, in here, Australia.
Yes.
So when I started as a GP in February, and it was a whole different thing. I didn't knew, like some of the GPs who work with me, the senior ones, they know all the specialists in town. So if you come with like some sort of a plastic surgery or something on your face, they would know, okay, this guy does face, this guy does knees, stuff like that. But one thing I really appreciated about most of the patients I met is that if you put an effort, like to help them, sometimes you mess up, but they would still appreciate you. So I had this patient, this young fellow who had a testosterone issue. Testosterone was dipping. He's a power lifter. It was affecting his life so much. And honestly, I didn't have a proper idea what to do with him. I refer him to the clinic, and he get a category 3, so which means within a year. So he's quite frustrated, and I refer to 2 private endocrinologists. Both of them declined the referral, saying they don't do like sex hormone like stuff. So I was scrambling, and then I tried few things, and I felt quite bad that I couldn't help this person. But a few weeks ago, he came in for something else, and when I questioned about him, he said, look, mate, we both tried, so I know how it is. I still at least I have the referral in the hospital system. I'm trying to do a few natural things, which he didn't disclose, but it wasn't something dangerous. But then he said, I'll see how it goes, but if it gets worse, I'll come back. Maybe we can bump up my referral. And he was quite grateful for what I could do. So it was something that I've because that would not happen as I believe in where I come from, because the doctor is known needs to know everything, needs to be sharp, it needs to happen. Like if they would not, some most cases, I would I don't have much experience as a working as a GP, but I would say like they would not appreciate your effort unless they see results, because they put that much amount of trust on the doctor to look after them, which is a bit unfortunate.
It's interesting.
But that's how it is, like specifically like in most BC settings, in like government hospitals, doctors does not have, like in a clinic there might be sometimes 400 patients seen by 5 doctors in a span of 5-6 hours. Needs to happen because some patients come from like 60-70 kilometers away by foot, by like on a push bike, and they have to go back. The next time won't be enough for them, so it's literally the resources and everything. So that's my take on that. So for the next question, Sab, so is there any particular, so as you described, apart from those, in the modern era, is there anything else the IMGs might see as a challenge?
Anything else? I guess the cultural aspects, sometimes the technical side of things, adjusting to an electronic system, prescribing. I think the interactions with other staff members, we talked about that flattened hierarchy and the different expectations between different specialties and within your department. I don't know. I think those are probably the main things.
Yeah.
Is there other things from your experiences that have been particular challenges?
I think the electronic medical system it's a bit of a challenge, but I mean it. One of the main complaints I've seen from my clients, like because I don't make the CV for them, I tried that, and I saw that has that has the opposite effect, because one thing is that you should be, if you're gonna, if someone's gonna do changes to your CV, it should be you, because I can't calibrate your skills. Like I don't know what you can exactly do. Whatever the changes I do, you might not agree with that. So what I would always say is I'll give detailed instructions to my clients. Do this, do that. Send it back to me. I'll have a look and I'll say what you can do better. One of them, some of the, I won't say the majority, but some of them say, Doctor, I can't do this. I have very poor IT skills. So what I say to them is that is something that you're going to have to work out anyway, because here everything happens through the electronic system, and if you struggle on that, even though you know what to do for a patient, you wouldn't be able to implement that if you're struggling with the software. So, but the good thing about the software is that the more you engage with it, the more easier it gets. Like your life becomes easier, like you don't have to like some like those when you chart medications for a patient, the reconciliation, you get everything, and the more you know, you can do something that might take 15 minutes, you can do it in 3 minutes. So that is something IMGs needs to really work on, and they're not that, I mean, there is a bit of a learning curve, but they're not that difficult. And especially in Townsville Hospital, they do a very comprehensive one-day program, which I have heard in certain hospitals they do like 45 minutes of a video lecture and expect you to do everything. In Townsville Hospital, they do a full day, like 8 hours, sort of like it's not that fast. It's well paced, and at the end of the, and then the next day you get to do another video module, so you can touch up, and then you can learn. And in emergency we use FirstNet, so you have to adapt, like it's not only power chart, so you have to adapt to those. And I think those challenges, it's just application, asking for help. I was taught by interns when I started out. They've seen me struggle to like adjust certain medications. They would see and come, they would say, I see what you're doing, but if you do this it will be easier.
Quicker, yeah.
So I mean, you can learn from pretty much anyone. And the pharmacist, I made tons of errors in the early days, like so many mistakes. And they would come down and they would sit down with me. They will show it to me what you need to do, and then So it is, I mean, with the technology, it is then, as we speak, certain changes are being added on to the very existing software that we work, but doesn't stop, like it doesn't cause things to like have a grinding halt or anything like that. So I mean, it's just most issues as an IMG. What I would think is that if you do the proper application and you ask for help, because like as even where I come from, doctors needs to know everything. Okay, if even for like physiotherapists, like you might not know anything about physiotherapy, but you should still be able to advise the physiotherapist. But it's not what happens here. If a physiotherapist comes and say, doctor, look, I can't send this patient home, we can't override that, because that's how things should be. But I have learned so many things from like even from like OTs as well. So it's I think more than half of the problems can be alleviated if you just be willing to learn. So next question. All right. So this is something that one of my clients recently told me. He interviewed for a very big hospital emergency department, and in the interview we prepared him for like all these acute care stuff like ST elevation, myocardial infarction, polytrauma, patient coming with a suspected head injury, closed clavicle fracture, open tibial fracture, everything. And then he got through the interview and he started working a few weeks ago. And he tells me, I learned everything that, like, all the acute care stuff, but I'm not doing anything. Like, I don't get to see like a myocardial infarction. I don't get to manage polytrauma patients. I feel like a glorified pathology collector because he's expected to draw bloods rather than assess the patients when they come after like a trauma. So as part of the team. So what I told him is that, like, one thing is that you should know the basics, like for any, especially for emergency care. And I think, as per my understanding, most RMOs are expected to sort of hold the fort until help arrives. Let's say patient gets bad, the seniors are away looking after someone else who's more sick, but then you should still be, as the next available senior, you should be able to hold the fort and manage the patient at least until help arrives. How much would you agree with that statement?
Yeah, I can see where your friend maybe felt like they had all that emergency experience, right?
Yeah.
But then when they've come over here, they've started down as a first year. Is that right? Because he came from an emergency. He'd done a lot of trauma and had prepared. And then when he come here,
his concerns were validated through the interview as well, because he was
Yes.
asked those questions.
yes,
And now he gets here and then he doesn't get to do
anything, yeah.
Like,
So I think maybe explaining to the audience how the emergency medicine training program starts,
Yeah.
I suppose. So if you are a junior doctor, probably less than 4 years experience, and you're working in the emergency, you'll often be a rotational RMO. So you'll come in, you'll do 10 weeks of ED, and then you'll go out. So those junior doctors will never or rarely get to go to resus and do the trauma, do the severe overdoses, intubations, and all those procedures. But what happens, and that's normal. So if you're an RMO, and you probably felt the same, because you were, I guess, as an RMO SHO, but you wouldn't be on the resus team, every shift. And then even your role in the resus team was more as blood taking, but the decision making was done at the foot of the bed by the consultant or the registrar. So that is completely normal in the system. You don't get to make the big decisions until you're a registrar level. And that's usually 4, 5, 6 years of experience. And more likely in our hospital, we have a training program. So you'll be an ED trainee on the training program. And that's when you belong in resus. Once you're a trainee, you've kind of earned that experience, or you've earned that time, and resus is where you belong with the consultant. So it's kind of, I feel, bad for your friend, but it's kind of, you have to work your way back up again, I guess. And that's probably a big challenge as well for IMGs that have come with, often with specialist qualifications, you know, and like yourself having many years of anesthetics and, you know, theatre and ICU, and then coming and then working as a, I guess, being treated as a second year RMO. So that is, I think psychologically, that's a big blow to someone with that experience, and you almost have to have that humility and try to swallow that, you know, that challenge and work your way back up again. So, but I think whether you're an IMG or whether you're a graduate from an Australian university, the first 3-4 years, you're not going to be in resus and you won't be doing those decisions. It's just how the training program works. So hopefully that explains. So then the question is, why did they ask those questions in the interview? I think it's more just seeing what experience you have had. Because if we had 50 applicants and 3 of them had worked in a trauma center, had dealt with, you know, in a big emergency department center, and then, you know, 47 had not, and you weren't able to answer those questions. If as an Australian hospital we're hiring people, then we'll take the ones for an emergency department, the ones with the emergency experience. So I think your friend sounds like they did very well and they got the job, but then, you know, I think the reality is that you'd start more as an RMO and work your way up.
He wasn't complaining. He was actually quite relieved. You know, like he was expected to, you know, like come to this new system and look after very ill patients. But you know, like he's I can understand his thinking as well. It's because, you know, one thing I would do when I was in resus, I would think, while I was waiting to collect the bloods and whatever, I would think what would I would do, and then the consultant will say something totally different, and then I would at least learn from that. So it's just, I mean, by observing you learn a lot as well. You cannot deny that. It depends on how you take the information. You know, you can be there, zone out, do your job and leave, or you can learn. So one of the things, Saf, is that about these interviews, one thing that I sort of like try to train my clients and everyone who does an interview is that it's not only your knowledge, it's about your personality as well. Because how you deal with other people, it's just you might be the most knowledgeable person, but you might not get the job. Because, you know, like as per my experience, I've seen some people when they have difficulty sort of navigating through the busyness or the conflicts that come their way, they don't do it properly, and in the end everybody else suffers, like the consultant, and there's a huge backlog. And one time I remember there was this handover given to one of my colleagues, 3 patients, none of them had notes done. So the colleague who got the handover was scrambling through. She had no idea what to do with these 3 patients who was in the department for like 5-6 hours already. And then, you know, like there's no notes, and even the consultant was confused. And that was the only time I ever noticed that the consultant had to call the RMO who left and get sort of him to say what needs to happen for these patients, because even the consultant he discussed with has also left, so nobody knows what's going on. And then in the end, my colleague he could not pick new patients. He had to look after those 3, get them sorted, and then because of that there were more patients for the other RMOs, and then we had to sort of sort them through, and then everything just sort of got so much worse. So what's your take on that?
I mean, I think your point, it's not about knowledge. Everybody has got a medical degree, has done anatomy, physiology, pathology, pharmacology. So we've all got that standard level. But the thing that will make the difference is working as a team and the communication, and that is by far, not just for IMGs, for any doctor, so that clear handover, documentation, if it's not written down, it never happened, right? So that's that's actually probably, for IMGs, one of the biggest challenges is the communication. You know, some of the complaints that I've had, some of the disappointment from different patients has come from a communication. Like an example was a patient complained to me saying, I don't want that doctor, and it was referring to an IMG doctor, because I can't understand what they're saying. And then when I heard the patient, I couldn't understand what the patient was saying because they had a really strong Australian accent. I was like, what the heck? So I could see there was a two-way problem. The Australian who was from, quite a small town out bush and had a very strong Australian accent couldn't understand the international doctor who also had an accent. And so communication is key. And I think in those situations, talking slowly, you might have to write things down. You might have to get another person to, translate or interpret. But that can be really, really difficult. So I agree. Knowledge is not always the issue. It's often your communication style and, being able to communicate effectively and break things down. Yeah.
All right. So one other issue that I think, at least I had when I began, is ethics. So being in a developed country, I would say, not just Western, ethics are quite important. How you practice medicine. In where I come from, ethics are treated as something in theory, not much so in practice. So if I tell you one of the most harrowing experience that I had my entire life, I was in an ENT clinic during my third year as a medical student. And ENT clinic means like I would be like here and the patient would be here. And there are certain other patients all around us. And then you leave and the other one who was on this chair will come and sit over here. So it's no privacy at all. And it's like 50 people in there. And there on top of it, there were 10 medical students in there as well with the doctors. So there are 2-3 doctors. So there's this patient who comes in who's like having this throat cancer, and the consultant gives him the bad news in front of everyone in the most, like, the worst way possible. Like, you have throat cancer, you're going to die. The patient broke down crying in the middle in front of all those people. So it's just, like it shocked me to no end. And surprisingly, the consultant didn't have any repercussions from what he did. He might face some sort of suspension if he did here, then in front of all those witnesses.
Yeah.
So something that worried me when I came here is that because I don't have that sort of practice, like just sort of that sense, and I knew what I like, ethics like privacy, autonomy, beneficence, justice, all those things, but I was quite worried that I might do something that might get me in trouble because the setting is different. Do you have any advice like regarding how an IMG can remedy that?
Yep. My advice would be treat others the way you would want to be treated. So always go back to that. So if you had throat cancer and you were struggling to breathe and and you were having to tell that patient, or if you were the patient, how would you want to be told? And I think that is the bottom line human ethical principle. I mean, that's like the golden rule, right? So whatever, that's cross-cultural. The thing with ethics, though, does have a cultural perspective. So if, how do I say this? I think that example, that's bad in any culture, right? Yeah, that's just wrong. But it might be that culturally, an example of privacy, right? So culturally, when you give some private information, in this culture, it might be one-on-one with the curtains closed in a private room. But in another culture, like for example, Samoan culture or maybe indigenous, Aboriginal culture, maybe Sri Lankan culture, you don't give any information to a person one-on-one. You give it with the father there, the mother there, the uncle, the auntie, whoever's paying the, housing fees. Or, it's a family. You have a family. You are never in isolation. So this idea of privacy is non-existent. So I think ethical principles as well. You have Western concepts of what is ethical, but then also depending on your culture. So we all agree on treating someone with respect. But how you treat someone with respect, do you look them in the eyes and you tell them straight like that? That's respectful in one culture. But if you look someone in the eyes directly, that's actually disrespectful in Samoan culture. You have to look, you look away. So respect is the principle, but how you practice that principle is culturally determined. But I think, so as an IMG coming to Australia and you think, oh, I want to treat people with respect, I don't want to accidentally do the wrong thing and be disrespectful, or I don't want to be, not show privacy or not show, um, not show confidentiality. I think if you just put that question back, is this how I would want to be treated? And that will get you out of trouble for most situations. So that's my first advice. The second advice is ask for help.
Yeah.
So just ask, hey, Zaf, is it ethical for me to just put 50 patients in a row and one by one tell them? And I'll be like, no, Supun, we can do better than that.
Let's do 10 first.
Start with 10. 50, that's too much. And we laugh about that now, but what's happening right now in our ED? We're ramping.
Yeah.
We've got ambulance stretchers in the corridor without individual beds, and we're examining patients, we're taking histories. So yes, ethical principle is one thing, practicality is another thing, but I think there's definitely a baseline respect. How would you like to be treated? And that'll get you out of trouble most times.
That's a very simple but extremely effective method, I would say. Yeah, it's just I mean, you do have resources here as well to well accommodate the privacy or whatever the situation that you would need. No consultant or a nurse will deny you of that. So it's just something that you, as you said, if I'm in this position, how would I want to be addressed or respected, or at least this news sort of broken to me in this way. So it's just something I 100% agree with that. And yeah. So speaking of Australia, the next question. So there are so many things unique to Australia where people are like the snakes. So when I was in med school, I had zero intention of coming to Australia because I didn't want to do any more exams. I was doing the final MBBS and I was like, okay, this is it. So there were a few friends who were interested. How I used to scare them is that I would ask them this question: how many out of the top 10 most poisonous snakes in the world, how much do you think is there in Australia? They would say 5, 4, and then I would say 10. So then it's just so that is actually the truth. And you might not see any snakes today because it's the off season. So so they're hiding. So, and also these spider bites, and actually it's just when you do the MC1 exam, it's a theory exam, so you get these questions a lot, like marine stickers, they go down to the specific, the blue, the bottle, blue bottle, and the irukanji.
Really?
Yeah.
The AMC exam?
Yeah, so
Oh,
they just sort of they're very specific on some questions at least. So IMGs are worried about this, sometimes how should I do this, how should I do that, should I study these, should I do some workshops, online stuff? What's your take on that?
So I guess there's two parts. One is passing the AMC exam. And I think I didn't realize it was in that depth.
Yeah.
So I think my advice is then, if that's in the exam, then definitely study those topics. And you'll find, I guess, there's a whole bank of past exam papers that MCQ past papers. So you'll get the idea of, the blue-ringed octopus, the blue-bottled jellyfish, the irukandji, the brown snakes. Use those past questions to help you gauge the depth of knowledge that you have to understand. So that's one thing. Now, the other part is in reality. So when you're treating real patients with snakebite in Townsville Hospital, don't stress. You, as an IMG, you will never be the one arriving in Australia and the next day you're making those big decisions. Although maybe if IMGs go out bush, do they have their first, generally you wouldn't be put over in the middle of,
there is I'm not 100%
Cloncurry
sure,
or somewhere.
but currently looking at things, there's a bit of a push for the IMGs to go for the peripheries given the incentives and all. One good example is that the AMC online exam, which I also did, was like it's now you there's no like any certain dates. They will have a exam and then you can send expression of interest emails, unlike the face-to-face one. So for those expression of interest, they will give priority to IMGs who are in the bush. Yeah. So yeah, and like for GP training programs, like I was part of the rural workforce, the pre-fellowship program before I got into the fellowship support program, the actual training program. And under the rural workforce, if you're working in MM3 or beyond, like 3, 4, like 5, 6, there are like scholarship programs where you can apply for like sometimes like 10,000 per term. It's a very good initiative, but from the looking at the grand scheme of things, there is a bit of a push towards the IMGs because I think they have fixed maybe to some degree in these metropolitan and regional regions these deficiencies in their workforce. So there's a bit of a push for the rural areas too.
So I guess, yeah, answering the second part. The first part is, study for the exams and learn snake bites, spider bites, jellyfish. In reality, when you're in Australia and you have a snake bite, there is always someone that can help. So even if you're in Cloncurry, you can still call retrieval services 24 hours a day and get a specialist advice. How much anti-venom should I give? How do I put the pressure bandage on? Not just that, we have a statewide toxicologist. So they're based in Brisbane usually, and they're an expert in overdoses and envenomation, so snake bites, spider bites. So the Australian health system is very well set up. Even if you're out bush, as long as you have access to a cell phone, you can call a specialist directly 24 hours a day, especially for those, weird, envenomations. So toxicologist, there's a 1300 free call number 24 hours a day. I use them as well. So even in Townsville Hospital we call and get advice. So don't worry when you're here. Yeah, you can always call up Supun and he'll give you some advice. No, there's always someone on the end of the phone that can give you a hand. But yeah, we see snake bites. I mean, how many snake bites have you seen that you've treated, even the ones that weren't envenomated, in the last, 6 months? You've seen?
Actually 0 in the last 6 months.
Actual snake bite? Maybe in the last year?
Maybe 1 or 2.
1 or 2, sure.
Yeah, they come with all the pressure bandage and everything because our ambulance services are doing an amazing job at that. So they are always on top of that, and then you just get to do. And there's a very specific guideline in the hospital too, which is like even the consultants will be like, look at the guy. And then we do have a bit of a thing because there's, I don't understand that 100%, but there's a difference between the snakes from Maggie Island and elsewhere. So it's just you would follow the guideline, and then almost always you're fine. And it's it's like, as you said, like you always have the help, and then first you learn, and then you do it by yourself. Yeah. All right. So it's just because I know you, Saf, in a bit of a personal note. I've been to your house. I wasn't invited after that, so it's just I have recognized you as a religious person. So IMGs, they come from heaps of different, at least in Sri Lanka, I would say, very different religious backgrounds, and they sort of have this question like, how much would I be, how I would be accepted, or like, will I be discriminated on this? So what's your take on that?
That's a very good question, and thank you for bringing it up. And it's probably a topic that's not really discussed very much in the workplace, the role of religion in the motivation for you at work, but also your religious practice and how that might overlap with your working life. It's very clear that there's Australian law that protects people against discrimination based on religion, race, sexual orientation, all of that. So Australia is a free country that you can practice religion whatever way you believe, as long as you're showing respect to other people who might be of a different religion, and I guess, trying to work towards a peaceful country. So I guess if you're worried about being discriminated against, there's very clear Queensland law, Queensland health rules that says you should be able to practice your religion in whatever way you can. Maybe I can share some personal examples, and that might help people who are watching maybe see how that could be in practice. So for me, as a Baha'i, member of the Baha'i faith, we do fasting for 19 days, and it's in the month of March. So for that, I usually ask for my roster to move some of my clinical shifts. I can move my shifts to one side or the other because I work part-time. So I do that for my fasting, and I ask the person doing the rostering, can I move it to this, for these reasons. Sometimes you don't even have to give the reason, but you can ask to have your shifts moved around. Also for like our daily obligatory prayer, we have, in Australia, in Queensland Health, you have 30 minutes compulsory, mandatory lunch break that everybody has access to. And then you have 2 10-minute pauses. They call it rest pause. So in a 10-hour shift, on paper, you should be able to have, 30 plus 20, so 50 minutes of rest break. I mean, how many times have we actually taken that full 15 minutes? That's another issue. But in terms of, if you need to have time for prayer during the middle of your shift, on your lunch break, if you need to, we do have a prayer room in the hospital, and that can be used by people from all different faith backgrounds. So yeah, you can use that 10 minutes if you need to pray in the afternoon, or some people use it to go out and smoke a cigarette, but anyway, that's a whole nother issue here in Australia. But yeah, and then, so I guess, fasting, prayer, we want to encourage you to continue your, religious and cultural practices, and we are, as a system, we encourage and support, you to be able to live the life you want to live. I guess the last thing is leave. So you may not know, but in Queensland Health, as shift workers in ED, we get 6 weeks of annual leave. So that's 6 weeks of paid time for you to take leave. So if you have any, religious holidays, you can use your annual leave. But on top of that, I just checked the policy this morning, but you have 10 days of, you can take unpaid leave. So no questions asked if you need up to 10 days in a year for religious ceremonies or cultural practices. So if you, have, and so that's, so for whatever religious reason you like. So there is laws in our hospital system that really tries to show value for those religious beliefs. And, in Australian society, about 40% of Australians associate themselves as being Christian. About 45% are Christian, so it's predominantly a Christian country. About 40% have no religion. So that might be different from some of the other countries around the world. And that leaves about 15% from all other different faiths. So, in that regard, your question is, will you be discriminated if you have, strong religious beliefs? I think coming to Australia, the answer is no, but just realize like 40% of people walking around have no religious belief. So it's not that you're going to be maybe persecuted by someone from another religion. It's more like that you're going to get a maybe a neutral or your own thing. But I don't know. So saying that, in principle, you should not be discriminated against. We do not accept, racism or religious bias. But I mean, the truth is, it does happen, and there's racial prejudice wherever you go, and Australia is no different. I don't know. Did I answer the question a bit? Yeah.
So I think about racism, it can be quite subtle in some occasions, and I think the very first meeting that we had with you, when we came here for like IMGs about talk about these discriminations, I realized I have been subjected to racism without even realizing. Like when you said, if they say like, sorry, I can't understand what you're saying because of your accent, that is, there is a bit of prejudice there. Like it's not something I'm doing on purpose. It's who am I, who I am. So it was just a quite bit of an eye opener. And then but to be honest, I haven't had that much of a prejudice of note. Most people do it like unintentionally. They like sometimes you might like people ask me a lot, where are you from, and it's not just sort of like as a racial remark. It's just they're genuinely curious. And whenever I say I'm from Sri Lanka, they have nothing but good stuff to tell me. Oh, the food was spicy. I saw elephants. I went there. Blah blah blah. I want to go back. Do you have any recommendations? So it is there. But some people, especially elderly people, like they 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 it's not coming from that, like from a prejudice perspective. But I mean, of course, if it makes you uncomfortable, you can either leave, and or you can sort of or you can give it back to them. So like I had one of my friends, patient has told her that her Uber driver was Indian when she went to see the patient. Okay, so like, are you from India? Because my Uber driver was Indian today. And then she said, oh, mine was Australian, so small. Something like, like it was like, and then so like, I mean, yeah, I mean, so yeah, so then that brings to my next question. So, the laws exist, you're being discriminated, but if you make the complaint, like one of my friends again had a very bad experience. He was working in a very busy hospital, and they were doing this horrendous thing, like they would roster him for nights in one rotation, and the very next day they would put him on to a different rotation where he has to do day shifts, which is like, yeah,
That's
no,
actually illegal.
illegal, yeah. So he actually ended up moving back to Sri Lanka because he didn't do anything, and he felt like he just sort of, he didn't have an proper idea that it was wrong and illegal. And when I told him like, why didn't you take action, he could have sued, he could have gotten like
And they were doing that continually,
the,
or it was just once?
I think few times, yeah. So, and then what he said was, like, look, man, I'm new to the system. I'm on my limited registration, and just sort of I got the job because of them. I have my registration because of them. So just didn't want to like go through it. And yeah, he ended up moving back. So all the investment he put through. Now I think hopefully he's now interviewing for other jobs. Hopefully. So is this like, do you recognize this as a myth, or will the IMG's concern would be actually heard if they take action against discrimination?
That's a really kind of sensitive issue, and I think the law is the law, but how that gets carried out can be can have quite a big variation depending on where you are. So I'm not sure where your friend worked, but you know, that is against the law to be, you need at least a 10-hour break, and especially after night shift, you're supposed to have more than that to be able to recover. So I can only speak of if that kind of issue happened in our hospital here.
Yeah.
So I can explain maybe for those listening is that we have a very supportive leadership team. Our deputy director, Natalie, really, she speaks very highly of our international medical graduates, and so she's very on board with supporting. And if there's any discrimination, there's a very specific pathway. So if, for example, you had a racist comment, I don't want to be treated by that XYZ doctor based on a racial stereotype, then there's a written, well, firstly, you can speak to your senior, and that can be escalated to our deputy director team. but we have an occupational violence policy, an OVP. So there's an actual, like a one-page form, and it says the date, the time, what was said, what was the discrimination, what was the issue that was faced. So racial discrimination, racism, uh, being shouted at or being spoken to rudely in our department is considered occupational violence. So words can have like I guess a violent effect, can be traumatic, can have a detrimental outcome for people's psychology. Like your friend, he felt like he couldn't speak up for what was an injustice. So there's a clear policy, and I think you've probably heard of it,
Yeah.
being drummed in the OVP. Fill out the OVP forms, because then those forms get collated, and then that can be escalated, and we can look at a system level. What are we doing wrong that's perpetuating this kind of behaviors? And it could be, we put signs up, we educate the staff that if you see this happening, the patient's rights are less important than the doctor's rights to being treated with dignity. So if there's a patient swearing, abusing, doing racist comments, then we have very clear instructions to call security and kick that patient out, no matter what their medical complaints are. Because if they're abusing and affecting the treatment of other patients and staff, then we don't want that patient here, whatever their medical problem is. Because being rude, being abusive is not stood for. Now, if that patient gets kicked out on the street, and then they change their mind and they're remorseful or apologetic, and then they decide that they want to talk in a appropriate way, then we'll happily accept them back in. But there has to be a level of respect that goes both ways. Anyway, this is a really important issue, and it's taken very seriously, especially in our department anyway.
All right, Saf. So I think we took long enough of your valuable time. So Saf is a father to four
Four
children.
kids now.
4 kids now, yeah. So he has heaps of responsibilities, and I'm extremely glad that you made up your time to sort of do this, which is something that I always wanted to do in my platform, which I couldn't do because of the other commitments that I had. So hopefully, I wish we can continue this. So the last question would be the most toughest question ever, but I don't know, like, so it's just, what would be the most single best advice you can give IMGs already working in Australia or planning to come and work in Australia?
Probably my biggest advice is when you come over here, have an open mind and try different things out. Try to embrace the Australian culture. Try to meet new people. Try to learn different ways of doing things. So, for example, have you been to a rugby game yet? Ah,
I've been, yeah.
yes, exactly.
Yeah.
So, when you come to Australia, go to a rugby game, go fishing, learn how to use a barbecue, go to the V8 supercars, go to the Strand, go to these like different musical festivals. Just try different things that might push you a little bit outside your comfort zone. But, we love having you here. We really value and appreciate IMGs and what they contribute to Australian, the health system. And so, yeah, my biggest advice is come here, come with an open mind, and just get out there and try, try these different things that Australia has to offer. And maybe I can end with some of the words that our Deputy Director, Natalie, I don't know if this is word for word. I hope she doesn't watch this and I get in trouble. But I still remember we were in a consultant meeting and we were talking about IMGs and how we can support them. And what Natalie said was, we are so thankful for international medical graduates. They have saved our staff shortages. They have really helped our department, and they're extremely valuable, that they've sacrificed their time, their lives, they've left their families, their culture, they've come all the way across the ocean to be with us, and we can't forget those sacrifices they've made, and it's not easy, but we really value those of you that can make it over here, and we're really grateful to have you as part of our team. Dr. Supun, it's been a pleasure.
Thank you. All right. So thank you so much for joining in. So as promised, we'll try to do more sort of like practical side of things, Saf, moving forward. And if you guys have any questions, we can of course save them for later. So thank you for joining. Have a good one. See ya.